Welcome back to the North of Patient podcast, Conversations on Health Beyond Care. It's been a minute since our last episode. As many of you already know, aside from my work as a family physician, I'm also the founder and CEO of a next-generation behavioral support platform for chronic diseases called Nimble Health. The seismic changes over the last few months in how we build and deliver value through software has kept myself and the team on our toes. However, I'm genuinely excited to be back behind the microphone. And perhaps now more than ever, it feels like an important time to slow down, have thoughtful conversations, and unpack the bigger questions around where healthcare is headed. Today's guest is someone who's been thinking about many of these questions long before most of us were talking about AI. Dr. Danny Sands is a primary care physician, a clinical informaticist, and one of the pioneers of participatory medicine. Throughout his career, he's helped shape everything from early electronic health records and patient portals to new ways of thinking about how patients and clinicians can work together as true partners in care. Before medicine, though, Danny had a very different passion, which was magic. As you'll hear, the lessons he learned as a magician about trust, presence, and human connection would go on to profoundly influence how he practiced medicine and how he thought about technology's role in healthcare. In our conversation, we explore the evolution of digital health from the earliest days of electronic records to today's large language models. We discuss why information alone is never enough, what clinicians uniquely bring to an age where everyone has access to AI, and why collaboration, not control, may be the defining principle of the next generation of healthcare. I thoroughly enjoyed this conversation, and I think you will too. Without further ado, here is Dr. Danny Sands. Danny, super excited to chat with you today. Really appreciate you taking the time here. It was something that really struck me that was interesting about your storied journey in terms of your career is that things started off, if I'm not mistaken, experimenting with magic and thinking about being a magician. Is that correct?
Yeah, before I made the decision to go off to college and do something more traditional, I actually was pretty set on being a magician for my life. When I announced that to my mother, because I had been doing magic my whole life almost, and I never had to work in retail or flip burgers or anything. I did magic. And when I went home one day after spending time with a lot of older folks who did this professionally, I said I was going to be a magician. That was what I was going to do. And somehow my mother didn't react with shock. She wisely said, well, that's very nice, Danny. I think you should do that. But in case the economy gets bad at some point, and you may want to have something that you do that's a fallback.
So another trick up your
more
sleeve.
Traditional. Yeah. So yeah, so that's why I went off to college and studied.
Yeah. How far did you take the magician path?
Well, I started magic when I was 5.5, honestly, and did my first paid performance at age 10 and did that throughout my time in school. I still performed magic when I was in college and medical school. But over time, I just had to let it go because I didn't have time to do everything, Puneet. I have always wanted to find a way to work magic or performing more broadly into my career. And so the way I have done that is I do a lot of public speaking. And to me, that's the performance buzz that I need. So that's the way to do it. And in fact, honestly, I chose medicine. I was motivated to do that because I read a paper when I was in college in a psychology class, and the paper was about the parallel. The paper was like from the 1800s, I think, or maybe the early 1900s, and it was about the parallels between the magician and the physician. The quote is something like this: "The physician, in large part, has to have the characteristics of a magician because he must inspire confidence." And that made me realize maybe I should choose medicine. But yeah, that's sort of how things started. Although I wasn't quite clear when I first went off to college whether it was going to be medicine or a field of engineering called operations research, or it was going to be law. three very different things.
Very different things indeed. Well, the interesting thing is the arc of the healer over time. Quite literally, went from the realm of magic, of different forms of magic, all the way to where we are today. Where we have kind of the allopathic science-based, evidence-based medicine. But even then, there is something about the fact that when you're in a room and you have an experienced, trained clinician in front of you, there is a healing quality to that itself. So I feel like the story of the healer and the magician still carries through even today.
Absolutely. You're absolutely right, Praneet.
So so tell me, I guess, a little bit about what it was like going through medical school for you, and what did you think your career was going to be about at that point in time? Did you foresee yourself being at this intersection of patient-centered care and technology and participatory medicine, or that wasn't quite part of the playbook?
No. Although when I gave up, I did have this technology background when I went off to college. I was sort of mostly self-taught, and then I took some courses in college. And as I was training in medicine and going through med school and then residency, one of the things I was struck by was that we weren't really taking advantage of computer technology to take better care of patients. I mean, we're at the margins, but not in a really significant way. And so much of training in medicine is regurgitating facts. And it's the attending saying to you, Mr. Sands, Mrs. Jones got admitted to the hospital last night with syncope. She fainted. And name 10 of the 50 known causes of syncope. Questions like that, or questions like, Mr. Smith got admitted to the hospital and he had a low potassium. What was his potassium a couple weeks ago when he was seen in his primary care doctor's office? All this stuff that I knew was better handled with computers. And yet we were being asked to regurgitate this information. I'm thinking why our brains could be used much more effectively. So that was frustrating to me at every stage of my training. And although I didn't know it yet, that laid the groundwork for me to want to do something with technology in healthcare, because I was so disappointed about what we were doing in medicine that I wanted to fix it. And that led to me coming upon this field called medical informatics. And there were a number of people who were trying to think differently about how we used technology in healthcare.
Who were the sorts of people inspiring you at the time, and what was happening in those days early in your career?
I think when I first went into medicine, I was really always a fan of medical history. I was really interested in medical history. I took a course in college, very interested in this. I loved the stories. And I think it was really the great physicians. It's William Osler that was an inspiration to me as I trained. But honestly, going into medicine, one of the reasons that I went into medicine, I have no doctors in the family, but we had a good friend of my father's was the head of neurology at the Cleveland Clinic at the time. And he encouraged me to, when I was in high school, go on rounds with him and sort of understand how medicine works and how doctors think. And to me, that was a really formative experience. And it really made me appreciating the whole picture of a patient and taking in all these facts and coming to a conclusion, and also just bonding with patients and making connections with patients. So I was really inspired by people like this and others that I have observed in medicine. So I think that was important to me too. So I think back in those days, though, honestly, I really thought of myself as just a physician. Just the real honest to goodness doctor. I don't think I had a clue of what specialty I wanted to do, but I knew I didn't want to look at just a thin slice of what a person was. I wanted to really look at the big picture. And I think that's probably why I ultimately decided I wanted to do primary care medicine.
And what was it like in primary care medicine at that point in time, where the role of technology was relatively minimal? And obviously you became involved in a lot of the championing and development and advancements of those technologies. What was that like early on?
Well, that's an interesting question. It's not like we didn't have computers, but Yeah, I think that when you don't have technology around, it's both. I would say it's scary, although you don't think of it that way because you don't know that there's an alternative, right? Most people just practiced, and it's kind of like today. If you couldn't do a web search or you couldn't use ChatGPT, what would you feel like? It's kind of that in a way, but again, we didn't know that we didn't have these things. It just weren't around. So you really had to depend on your own skills, your own knowledge, to a great deal. But as I said, it's also knowing what the potential is. It's also scary because people made mistakes. Yeah.
So when you think about the roles that as a primary care physician there were to be able to better incorporate technology, what did that look like in terms of how you first got your hands on being able to implement technology into primary care?
Well, I was really fortunate. When I was looking around and trying to figure out who I could work with, who was in medical informatics, who was really trying to use this technology, I got connected with the Beth Israel, which is now Beth Israel Deaconess in Boston, and this is and was at the time a really remarkable place because this was an institution that Warner Slack and Howard Bleich had introduced a hospital information system in 1978. So really early pioneers in this space. This was a functioning hospital information system. I came on there, and this was the playground in which I worked. This is where I trained, and it was because this was a part of the way we delivered care. Um, it was part of everybody's life. I was accepted as a fellow at the Center for Clinical Computing in at Boston's Beth Israel, which was part of Harvard and Beth Israel. And they didn't always accept fellows. I was the fellow,
Mm-hmm.
and some years they didn't have any fellows, but they accepted me, which I was thrilled about. Well, the person who actually hired me was a level under Warner and Howard, and it was Charlie Safran. And Charlie Safran hired me, and I was supposed to start on this particular date. And what he failed to tell me is that he was going to be away on sabbatical for a few months. So he was my direct supervisor. He was going to be away. So Howard and Warner had to figure out something to do with me. Said, what am I going to do with this kid? And one of the things that they did is they said, Danny, I think what you need to understand is how information technology touches everybody across the medical center. So we are going to set up meetings with you to meet people across the medical center who do all different things and they interact with information different ways. People from the billing department, people from the lab, radiology, and so on. And by the way, this is generally an inpatient system in those days. And they set up all these appointments for me, lasting probably a week or two. And I thought at the time they were really just trying to get rid of me, trying to find something for just to get me out of the office. But I dutifully went around and I met with the people and I learned how they interacted with the technology and what where the opportunities were and so on. And what I realized in retrospect, many years later, is that was one of the most useful experiences that I ever had.
Yeah.
Really useful. And just being in this environment was just really extraordinary. And in fact, I didn't appreciate how different it was at most other healthcare institutions. This is in the early 90s. And eventually I was learning how to code in this environment and develop things. And in this kind of an environment, Puneet, it was fascinating because my metric of success was if I developed something and I put it live without telling anybody about it, I just put it live, people would come across it accidentally and they would use it and they would tell other people about it. And so my metric of success was watching utilization rise over time without any advertisement. And I learned so many lessons there. among which are the dictum that I think Warner or Howard had, I can't remember who it was from, which is that the utility of a clinical information system is inversely related to the size of its manual.
Yep.
The idea being that things
Yeah,
need to be intuitive,
totally.
right? You don't have a manual to use things that you see on your phone, right? We just use them. So that was important. It was important to learn how to create scalable technologies that were intuitive, that really, by the way, we only had an 80 by 24 character interface to work with. It wasn't GUIs. And so I had to be really clever with how you develop a user interface in that kind of environment. So all those lessons were extremely important lessons for me. I developed my first application that went into the wild was a set of clinical calculations for clinical decision support. And this went live and skyrocketed in use over the weeks as people found out about it. And very useful technology, which, by the way, I had originally developed a set of clinical calculations like this when I was using a programmable calculator in medical school. And programmable calculators back then were very different than what they are now. And I developed this because I thought, again, I wasn't even doing informatics yet, but I said, it's ridiculous for people to have to memorize the formula for an AA gradient or an estimated creatinine clearance or any of these number of calculations that we use. And we have to use them all the time. And when you don't know the formula, you're either going to guess or you're going to waste time trying to find out what it is. And you're going to make mistakes. Furthermore, if you have to transcribe data from the patient's records, their test results, for example, into these formulas, again, another opportunity for error. And what I saw, what I saw in this environment at Beth Israel is I can allow someone to choose a formula, identify a patient, and pull in live lab data about that patient and demographic data and their weights and so on. So that was a huge breakthrough. So yes, this was useful. And then I became part of the team that developed the electronic health record that sat on top of that infrastructure, which was called the OMR. And Puneet, that OMR, that electronic health record, I should step back. I was a user of that. So the people who were developing that, I worked with David Wren and Charlie Safran on that. We were all practicing part of our time as well. And so we were both using the system and developing it. So our colleagues would often reach out to us and say, I wish the system would do this, right? So that was a great experience. And then I transitioned from being a fellow or training, and I gradually transitioned into taking on operational responsibility for the OMR and other clinical systems. And I stayed there for almost 14 years.
That's an incredible journey, and I can definitely relate to that. You might know that I also helped develop an electronic medical record system in Canada, and very similar journey in that, my co-founder and colleague was also a practicing family physician, and there's something to be said about being able to relate to the end user, and especially in the context of supporting other healthcare professionals as a colleague, as opposed to somebody bringing in something external. You're not really bringing in a technology as much as you are solving a problem. And
Yes,
it's incredibly gratifying to do that. And then at the same time,
it
be able
is.
to go and practice and actually see the fruits of your labor, a day or two later. So
Exactly.
yeah,
That's exactly right.
it's
Yeah.
it's an addictive thing as well, because you start, looking for other problems to be able to fix. And I think it's such a rewarding time to be around, especially right now, where the ability to be able to solve these problems is increasing in speed with the tools available to us. And the question often becomes, what are the right problems to solve, and are we thinking about all the people involved in that?
Yes, absolutely.
So maybe that's a good segue to talk a little bit about, I guess the field or the space of participatory medicine. It's such an interesting one because putting words or giving a name to something, I think, is hugely important to help you understand the importance of why you need to be able to engage with people in certain ways. But can you talk a little bit about how the Society for Participatory Medicine began, and your work with Dave deBronkart?
Sure. So going back to the time I was at Beth Israel for all those years, um, I went into informatics because, as I said, I was really trying to empower clinicians with better information technology tools, to take better care of patients. But in my own practice, as I was taking care of patients, one of the things I realized is that these technology tools can be equally empowering to patients, even more so, patients and family caregivers and so on. And that was kind of an aha moment for me. That started when I was, so at Beth Israel, we were pretty advanced from a technology standpoint. And one of the things we were doing quite early, in the early 90s, was we had email available to all employees, clinical or non-clinical. And and at the time, I was building my practice, my primary care practice, and we had this joint venture with a health insurance company, and it was anybody who was an employee or family of an employee, they were encouraged to choose a primary care doctor from Beth Israel. So one of the things I realized early on is I said, "Hi, all these people have email addresses. This is amazing." So I started communicating with my patients through email. It seemed perfectly natural to me. And I said, let me see what happens, right? My colleagues thought I was nuts, but I actually encouraged my patients to do this with me. And I found that they really found it very useful. And I found it really useful as well. I mean, it allows us to time shift. It allows patients who are felt frustrated and time constrained in the emergency department. They can take all the time they want to create an email outside. Over time, I developed best practices for how to do this. And that led to my co-authoring the very first guidelines about how to use email with patients way back in 1998. And at that time, this was post World Wide Web. And so now everybody starts getting an email address, right? Now, my colleagues all thought I was nuts still because, why would you want to exchange email with patients, right? It's more work for the doctors to do. But I found it very useful, as I said, and they did as well. Well, that then led to my becoming involved in a project at Beth Israel to develop a patient portal. So back starting in 1999 and then going live in 2000, we developed one of the nation's first health system patient portals, and that was called Patient Site. And one of the things that it did, of course, like any patient portal, is it allowed you to do secure communication between the doctor and the patient. So that led to a whole bunch of work on my part to spread the word about not just email, but about patient portals. And that led me to become involved in projects around personal health records because patients could see their records through this. And I became part of, I was pulled into a group that was assembled by a man named Tom Ferguson. Now, Tom Ferguson had gone to medical school. He went to Yale, but never practiced. Instead, he became sort of a medical anthropologist, observing healthcare, looking at what happens. He wrote, I have it on my shelf over here. He published a magazine back in the 70s called Medical Self-Care to sort of demystify medicine and tell patients they should understand their bodies, they should understand healthcare. And he was really passionate about that. Well, when the World Wide Web democratized access to information, Tom became really interested about how this new breed of patients that he called e-patients would be able to leverage this technology to have a different kind of role in their healthcare. And Tom was as I said, he was an observer of the system, an anthropologist, but he's also a collector of people. And he brought together over time, he assembled kind of a group of people who were all interested in this in different ways. So I was interested in what happens between the patient and the doctor and the use of communication technologies and patients seeing their records. We had people who were running online support communities starting at the dawn of the web and even before. We had people who were researching all of this. So an interesting group of people that was pulled together, about a dozen of us. And every year, Tom would bring us together for a long weekend to talk about the challenges and the opportunities about this technology. And we'd share information and advise each other in our careers and do all kinds of interesting things. Dave wasn't a part of that group yet. We'll come to Dave in a minute since you asked about him. So we would get together year after year. And then in 2006, Tom passed away. He was an e-patient to the end. And I should mention, e-patient is not what you think. It's not electronic. The e-patient is engaged, educated, empowered, and enlightened. And Tom was totally that. He was on fire. He was totally empowered. But unfortunately, he died in 2006. And the group of us kept meeting year after year. And we decided that we wanted to build on this legacy and this work that we were doing. One of the things that Tom did is he was writing a white paper about e-patients that I'm sure you've looked at on our website. And we had to finish this posthumously. We completed that white paper. But we wanted to do something to make this a reality. And at that point, I had brought e-patient Dave into this whole thing. Dave was and is a patient of mine in primary care. And Dave has his own story about how he was diagnosed with metastatic cancer one day at just after a checkup. And it's a story that we both tell together about how we wove technology through his diagnosis and his treatment. And fortunately, he's still with us today after many years. But after he had gone through this and it looked like he was making it and we were doing work together, I brought him into this group. And together, what we did, all of us, is we created this organization, this not-for-profit called the Society for Participatory Medicine.
That's super interesting. And in terms of the experience of coming together in that type of a group, first of all, I think it's so important and probably connects also back to your experiences having seen the various other stakeholders within healthcare. So you become a little bit more aware of the fact that even the delivery of healthcare itself is something that requires engaging and connecting with your colleagues and peers, often whom you might not necessarily appreciate the realities and hardships that they have. I know I can speak from my own experience as thinking about how we implement technology in a clinical setting, the role that each potential person who touches that system, maybe even indirectly, whom gets impacted by that, how important it is for them to understand why that's happening and understand the value of being included in that journey. When you think about participatory medicine, how do you think about the communication of that value? Like how do other clinicians see the value of changing how they practice?
Well, since you've dealt with practice transformation in your career, you know that change is hard.
Mm-hmm.
Change is hard for physicians, especially. Physicians are a conservative bunch. They don't like to change. They're creatures of habit. As you know, it takes 17 years on average for a proven innovation to penetrate healthcare. In my career, I've had to try to convince physicians to give up paper and move to electronic health records, which is hard. And in this idea of participatory medicine, that's a different kind of transformation. You see, I think too often we believe healthcare is I'm going to use a metaphor here. I think we treat healthcare as if it were a car wash. And what I mean by that is not to disparage healthcare, but what I mean by that is that the patient thinks that they're going to cruise. The patient is the car that is dirty or unhealthy, right? And that's the metaphor. And they're passing through this healthcare system car wash, and they're getting health sprinkled on them as they cruise through this system passively. And somehow they come out the other side and they're healthy. And I think that many patients feel that way about healthcare because they've been treated that way. And many physicians kind of feel that way too. We are told in the business world, right, that healthcare is an industrial process, or it's a service industry, it's a consultation. All these things that don't quite capture the essence of healthcare and how it can be so powerful. I think, and this is what we talk about at the society, that we have to think differently about healthcare. Healthcare is better practiced as a collaboration between the doctor and the patient. And just like any collaboration, any healthy collaboration, right? It's about sharing of information, open communication, and engagement, right? All these things are really important. So that's the way we need to be thinking about healthcare. And that's really what participatory medicine is in a nutshell. We say that collaboration is the best medicine. We're at a time now in Western medicine, probably this, from what I've read, the same in Canada as the US, where we have unprecedented burnout by physicians. In the US, at least, not only is there unprecedented burnout, but physician suicide is at an all-time high. We could talk about all the different factors that go into that, but I would argue that part of that is feeling that we're just part of this chain of events. We're part of this process. We're like, we're working on a conveyor belt, just passing patients through, waiting for the next patient to come
It's
through.
a disenfranchised state. Yeah.
It is a disenfranchised state.
Yeah.
And we need to help physicians find meaning in what they are doing. And if we go back to why physicians went into healthcare, it is not that. They don't want to do that. And so we can find meaning by connecting with our patients, by collaborating with them, by feeling differently about what healthcare is.
100%. I agree with you. And, it's funny because even in my journey when we were implementing a new electronic health record platform, and a big part of the ethos of that journey was around integrating, patient-reported outcome measurements and streamlining the workflow such that you'd have to think less about documentation. This was, 2010, 2015 in that spectrum. So much of what I felt like ultimately we were trying to, to sell, if you will, was this feeling that people could have where they could go back to just focusing on the patient. And that's powerful, right? This fact that, hey, imagine this was really just about you being able to be there in that room, to use your knowledge and to have the ability to be present and just help this person through something because you have the ability to help. And I feel like even today, while in certain ways, obviously we've gotten better, it's not happening fast enough. And what do you feel like are the challenges there structurally? Because, as you know, I don't think burnout has gotten that much better, even though now we do have tools, whether it's ambient scribe and other technologies that are helping. What do you think it is that's holding things back? Why do people still feel that way? Clinicians, I guess.
I think there are a number of factors, Puneet. One is the declining reimbursements for doctors' time, and consequently practices and health systems, in order to make it work, are condensing the time we have for patients. They're shrinking it. And so we don't have enough time to really take care of our patients. And that's stressful. At the same time, we're being forced to use electronic health records that honestly have terrible user experiences, terrible user interfaces. And I don't have any connection with any of the systems, but it's almost like they don't care to make it better. They don't have to, because people are going to buy them for financial reasons, and they have to buy something. And so we have these challenges with the user experience. And so, in my early days, and I'm teaching people about electronic health records, how important they are, one of the things that comes on the heels of that is how to use an electronic health record so it's not interfering with the practice. You need to teach EHR etiquette. How do you not get in the way of that human connection? And I still teach people about this, but obviously the harder it is to interact with the computer, and the less time you have, the more stressful it is, and the less time you're going to be spending being present for the patient. There are still ways to do it, but we've got to figure out how to do that. And I think that, for many people, ambient scribes may be a piece of the solution. There are other ways to do it, but I think it's the declining reimbursement, and therefore the declining amount of time that's allocated to care. It's the electronic health record that I think is really a huge barrier to some of this. And then, honestly, I think burnout kind of feeds on itself, which is that, when doctors feel happy, they're going to do a better job engaging with patients. They're going to feel happier. On the other hand, if you're engaging with patients and you have a meaningful connection with patients, you're going to have less burnout. But I feel like the more burned out people are, the more it's going to make it's going to burn them out more. It's sort of a vicious cycle.
Yeah, I mean, I have a number of thoughts on that, and maybe I'll unpack the piece around the electronic medical record space because obviously, having been there relatively, I mean, in the course of the last 10 years, um, I will say that there's kind of an inverse relationship between the usability of a system and the extent to which it's been certified or regulated for use. And we certainly saw this in the Canadian context where, you start with a platform that's completely free and devoid of any of the requirements, if you will, to be able to connect into health information systems and so forth. And you can use creativity and imagination and really be solely focused on the user experience. And then the further you go from jurisdiction to jurisdiction, region to region, state to state, province to province, to meet all the requirements, the more it begins to look less like what you intended it to be and more like everything else. And I certainly don't mean to say that that's the only reason why it happens, but I do feel like we've sort of we've shackled the ability for technology to sort of be purpose driven, and rather it's become sort of a regulation driven. And you ultimately feel like you're interacting with a checklist, and now we're using technology to automate the checklist. But I do think there's something there that often doesn't get spoken about, especially for people who don't end up being on the other side of building tools, and I'm sure you know this.
Yeah, I think you're right, Puneet, and I don't know if it's at least in the U.S. It's not regulation about what the EHR has to do, but maybe regulations about what kind of data needs to be acquired. I still think that there's a way to make this better. I really had a vision once upon a time that, all you needed is to abstract the presentation layer from the business layer,
Yeah.
and you could create any kind of user interface you want, whatever experience you want, and which would be great. And I think we kind of get to that with Smart on Fire, for example.
Mm-hmm.
But still, we have the primacy of the electronic health records and the challenge of really deeply interacting with them.
Mm-hmm.
At a technology standpoint on that, sorry.
Yeah, and we might just be living at a time where what you're describing will be possible, right? In terms of being able to verbally, to have a conversation with somebody and for the system to be able to show you what it is you need to see to make that conversation more meaningful, to spin up the interface as per necessity. And I think if we obviously respect all the necessary data structures underneath, and as you mentioned, Smart on Fire, and have the correct ontologies, then you can allow the UI to be completely free of that. Yeah.
Yeah, I agree with you. And, it's one of the things we'll probably get to it at some point. The company that I'm working with right now, one of the things we're trying to do is make it possible to have a more efficient visit. And highlight the information that needs to be highlighted, take care of patients in between visits instead of all in the visits, because visits can't happen all the time and there's too much to do.
Yeah, and actually, I wanted to unpack one more thing that you mentioned as well, which was kind of the other things contributing to burnout. And one of the things that I've sort of been observant of is if you think about kind of the trajectory of where medical education has gotten, how much more complicated treatment pathways have gotten. Obviously, there's the hyper specialization and the fragmentation of care, especially when you think about something like the realities of primary care and family medicine. You don't get left with very many tools that actually pertain to, again, healthcare versus sick care. And I do feel like medical education itself has not been able to transform in a way to be able to continue to empower physicians, especially primary care, preventive health, family physicians, to be able to do health and wellness. Like how do you prevent disease beyond, the 10 or 20 kind of guideline based preventative health tests that you need to do, which are important, and not to downplay them, but there's so much more to it that I feel like people are hungry for, and increasingly they don't feel like primary care and family medicine is the place to go to for that.
I think that's a really important observation. And, the question always comes up, well, if we're going to teach people about technology, or we're going to teach people about participatory medicine, this should be done early, like when people are in medical school or in nursing school or whatever. But the question always comes up, what are you going to take out of the curriculum in order to put that in? Because it's already chock full. And as you point out, we already do a terrible job teaching medical students enough about prevention, about nutrition, about exercise. There's just so many things that are, healthcare, not sick care, that we don't teach people. And I'm not saying we have to remove the sick care things in order to do the healthcare things, but boy, it's a big problem with Western society if all we focus our healthcare dollars on is sick care. So we need to find a better way to do that, because, that just leads, it sort of drives this whole medical industrial complex, right? Because the more sick people are, the less you're doing prevention, then the more specialists you need. We need more effective interventions. I think that leads to this whole question, not just about education, which you brought up, but about, the value of primary care. Because I think largely primary care is undervalued. And I don't know, I know the payment system is different province by province in Canada where you are, but in the United States, primary care is totally undervalued, underpaid, which is one of the reasons that it attracts the fewest number of students, to pursue residencies in that. And that's a tremendous problem, because in communities where we have good primary care, we have a good network of primary care, where primary care is felt to be important, that's where we have lower costs and better outcomes and so on. And we need to go back to that. Now, I'm fortunate I work in a healthcare system where they're investing in primary care. Beth Israel Leahy is the part of the network I'm in, and they're investing in primary care because they understand this is so important and it really drives everything else. But I think we have so many parts of the country where people don't have access to primary care because there aren't enough primary care physicians, and it's only getting worse.
So that raises an interesting question, which is, given that we know that there's major gaps in access, and we're now at a time where technology is evolving in a direction where we can potentially begin to deliver almost immediate access, at least in the form of LLM-based companionship and support. How do you balance that with the potential erosion of the value of primary care, with the need for being able to disseminate and support people who are getting zero access to anything? What's the way in which you reconcile those two realities?
I think that this issue of immediate access to information is an issue that's, of course, not new. And as I said, I was talking about this stuff at the dawn of the web, when all of a sudden there were all these healthcare websites out there. And the question was, well, maybe what doctors do is not that important, because you have access to, it wasn't even Google in those days, pre-Google, you have access to the web, right? And in some ways that access to information goes back probably to even the 70s, where I can remember as a kid in high school, you could go to the local Barnes and Noble, and you could actually see some medical textbooks in there. Grey's Anatomy. That's really a book, not a TV show, but Grey's Anatomy, for example. And you could see these things, and they were available to everybody. With the access to computer technology and then to the World Wide Web, everybody had access to the world's medical literature, right? That was stunning as well. And it was even before the web. We had things like Grateful Med and Paper Chase and things like that people could subscribe to. At any rate, so the democratization of information has been going on for quite a while. And here's the thing, is that many physicians grew up in an era in which they feel that their value is to be a font of knowledge. They need to just know stuff because we were trained to regurgitate facts. And the idea is that led to this idea of what we call in economics and in warfare, information asymmetry, where one party has all the information and the other party has none of the information. They don't have an equal amount of information. And so the person who has access to the information can take advantage of the other party in war and economics. In medicine, there's still that concept really exists, and physicians are comfortable with this. They were comfortable being the know-it-all when they were in medical school and learning all that information, memorizing it, and having it available. But over time, what we're realizing is that patients do have access to all this information. And so although we might be comfortable with the model of information asymmetry, it's not, it is not realistic in an era in which everybody has access to information from the web, today from LLMs and so on. So the question is, so the answer is we need to embrace information symmetry. And we need to ask ourselves, well, what are we bringing to the table? Because it's not just information. It's not like, oh, please, doctor, teach me about my diabetes. It's now patients have access to that information, not just information about diabetes, but they all know all their test results and so on, right? They know everything. So we need to raise the level of discussion to a whole new plane, and it really has more value when we're doing that. So that's what it is. We need to be bringing our clinical wisdom, our years of experience. Those are the things we need to bring to the table. We need to recognize patients have access to the raw information, and they have access to themselves. They are an expert in their own bodies, right? We need to respect that. But physicians have expertise in medicine. We spent years learning medicine, and we have wisdom and experience, and that's what we bring to the table. So that's the kind of collaboration that I'm talking about. Now, let's go on to talk a little bit more about LLMs, if that's okay, Puneet, because I think it's an important topic. It's the latest iteration, as I said, of patients having access to information, and it's arguably smarter than just doing a web search, but it can make mistakes too. And we need to recognize that patients aren't always going to get the right information here, just like in the days of just searching the web, they wouldn't always get the right information. So part of it is that patients need to be comfortable bringing that information to their healthcare professionals to discuss that. And I used to say the same thing about information they find on the web. Have that conversation. Don't just go make your own decisions based on your own limited knowledge and what you're Googling about, or, in this case, what you're chatting about. Have that conversation. I'd rather a patient have a background, some knowledge that they've already done some research there, because then we can have a more important, more significant conversation. But I think that also, there's another piece of this too, which is that physicians are using LLMs as well. As you know, open evidence is a very popular tool. I think it's available in Canada as well, right?
Absolutely, yeah. It's very commonly used here.
And it's very, very popular right now, and it's usually correct. But physicians are using it, whatever. But physicians are in their own little world looking at their LLMs. They're doing open evidence or what have you. And patients are in their own little worlds looking at ChatGPT or Gemini, what have you. And we're kind of in our own worlds, and it would be more powerful if we could interact in some way together with the same system.
Well, going back to your point about information asymmetry, it always raises the question, why does open evidence not have an ability for patients to access the same treasure trove of validated knowledge, right? Like, why are we forcing them out of that? And I know there's lots of interesting conversations happening around what's the way to do that. And I think, there's a feeling that some of it comes from protectionism, whether it's a protectionism in the form of like, oh, my time, if we give this information to patients, they'll have questions. I won't have time to deal with their questions. Or, oh, maybe it's dangerous we give them information because then they might make, certain decisions or draw wrong conclusions. But needless to say, I think we're on the same page, which is that's obviously not in people's interest, nor is that the right way to think about it. But I feel like we're also at a place where medical education needs to evolve a little bit more quickly as well, to double down on the value proposition of physicians and family docs in order to be able to say, this is how we're evolving and meeting the unique and bespoke needs of delivering high quality care. What are your thoughts on that piece? Like, is there enough happening on the medical school side to evolve? Do you worry that they
Yeah.
can't move fast enough?
Well, I think it's a challenge. Upending a medical education system is challenging, and I think all my friends who work in medical education are struggling with this, right? Because we all know, and not just medical education, because of course this permeates down to lower schools as well, high schools and colleges and so on. Educators are dealing with this throughout. Is that what do we do about this? How do we teach people in this environment? How do we make sure that their thoughts are their own thoughts and they're actually learning how to do this clinical reasoning when information is available at their fingertips? And, I think that part of I don't know the answer to this, Puneet. I'm not clever enough to think about that, but I do know that part of the answer is recognizing the humans need to be in the loop to check things. Because the problem is that if we accept this information and we don't question it, we don't look critically at it, we're going to make mistakes. And that's nobody's fault but our own. And so we still need to be teaching these critical thinking skills of our residents, our medical students, our college students, our high school students, and so on. I just heard on the news this morning that some study came out from a firm showing that, some massive number of high school students are using AI to do their work. Some statistic like that. And of course, what does that do to us as a society?
It's a balance, right? And I think it's the ability for us to be able to remain enough in control and have the faculties to be able to make decisions independent of when a server goes down or when when access to tool may not be there. With the fact that there's so much good that can come from just the democratization of intelligence and access to information.
That's right. The answer isn't to just shut it down and ignore that it's there, but we got to figure out what to do when it's not right or when the server fails, as you said. There was a short story written by H.G. Wells, and I think it was called When the Machine Stops. And it sort of asked this question. It's a society of people living in the future underground, and everything in their lives is run by a computer. But all the people who knew how to program that computer have died. So what happens? So it's an interesting philosophical question, but we've got to think about that as a society.
Oh, totally. And I mean, in that context, that's happening even faster when even the technologists and engineers building a lot of these tools are handing over keys to the models to continue to build the tools themselves. So I feel like we're giving up control perhaps a little bit sooner than it may make sense to. But what when we think about the need for society to respond, right now is interesting because there are so many things happening in different parts of the world in relation to how regions are responding to the utilization of technology. And I know, for example, I think it was in Ohio where they passed a rule to allow LLMs to be able to prescribe to.
That was in Utah.
It was in Utah.
Yeah.
So that happened, and then in China they mentioned that they're in rural communities they're providing direct access to AI for primary care for some 100 million people. What are your thoughts? Like when these sort of things happen, how do you reconcile that?
So first of all, it's an interesting thing about Utah, which is that a firm went in and found out that they could trick the system into giving them massive doses of opioids and other things. So, we've got to test these systems before turning them loose. But I think going back to the other thing about primary care, if we don't have enough primary care physicians, how do we scale the system more effectively? And surely technology needs to be a part of that answer. And probably today, LLMs are a part of that solution. So a number of years ago, I worked for a company called Conversa Health, which was a company that was kind of dealing with how do we scale the healthcare system and how do we do autonomous outreach to populations of patients to help them remain in control with their health conditions or reach their health goals. So fast forward a number of years, because I'm really passionate about this. We've got to figure out how to do this. How do we scale our system? So 4 months ago or so, 5 months ago, I joined a company called Lumeris, that is actually trying to do something similar. But of course, we're using modern technologies. We're getting information from the healthcare system, deep information, and we're using LLMs. And we're very careful about how we gather information from patients. And we're doing this to extend the healthcare system. It's because we try to cram too much into the doctor's practices. They can't do everything. A study was published, I think it was the Journal of General Internal Medicine, that showed it would take, for a typical panel of patients, typical primary care physician would have to spend 26 hours a day to do all the things that need to be done to take care of that panel of patients. I'm sure you've seen that. So how do we decompress that? How do we make that better? How do we make it possible to take care of a panel of patients in less time? Because we're using autonomous agents, we're using technology, and we're leveraging it appropriately. How does that change? How does that transform healthcare? How does that change the way we think about healthcare? How does that maybe improve joy of practice? There are all kinds of really interesting things that come out of that. And then you could extrapolate that, Puneet, and you could say, okay, well, that's how we extend an existing primary care network. But what do we do in places that don't have primary care? Can we create a system using maybe not an existing brick and mortar set of primary care doctors, but maybe it's a set of primary care doctors through telehealth services? And so that's the next frontier. And in the United States, there is a rural health transformation project that is funding states to do these kind of projects right now.
Yeah, I mean, I think it's incredibly exciting, and I think a lot of it comes down to what are we trying to move towards, and what does good look like, which is a big part of what I try to uncover kind of in these conversations is, what is the not even the ideal state, but what is a bright future that we can describe and begin to actually move towards. So on that vein, what are your thoughts about, I don't want to say 5 years from now, because I feel like now that's it's hard to look that far ahead, but in the future, how would you describe a good outcome with respect to how we reconcile the use of technology, maybe a few steps beyond the obvious of the incorporation of LLMs, but what does good look like?
Well, I think right now, and this is unfortunate, but I think going back to the EHRs, right now, I think physicians view technology as something that's being done to them instead of being done for them. That is, they don't look at this as something that's helping them, that's helping them do a better job, because it is honestly so onerous to interact with, right? So I envision a future in which physicians find that actually this is helpful, that I'm working side by side with this technology, whether it's an EHR, LLMs that are augmenting that, or what have you, that it's really on my side. It's really working with me, and it's helping me. And I appreciate the advice that it's giving me, the help it's giving my patients. And at the same time, I want my patients to feel that these tools are helping them as well. I think that a lot of patients get benefit today out of their patient portals, which is great. I'm a big fan. But I think in the future, it's going to be, my doctor has this AI tool that's a part of their healthcare team. And I find it really helpful because it's helping me stay on track with my diabetes, and it's helping me with my exercise goals and so on. And that's, I view that AI agent is my friend. It's a part of my team. It's giving me support.
Yeah, absolutely. And I can imagine a future where we can even see, the agents of your healthcare system talking to your own agents to converse and ultimately determine that you need a follow-up appointment, and then get your permission on that and make all those things happen. Really make, many of the administrative kind of often painful aspects of healthcare a little bit invisible. Let a lot of the burden be taken at that layer, and allow the human really to be presented with the information, the options, and then the ability to be able to do what's best for them.
Exactly. Yes. Love that.
It kind of brings me back to one of my favorite quotes, which actually works really well in this context, which is, I believe it's any sufficiently advanced technology is indistinguishable from magic, which I feel like is I think summarizes your career and your work so well.
Yeah. I think it's a very, very good quote. I do I do like that, and I think that that's true. And we need to, to that point, we need to feel that this is not just working with us, but it just becomes a part of the background, kind of the way, a lot of technologies are. When they become magic, they are just part of what we do, right? We don't think about the fact that we're carrying these devices in our pockets that are really magnificent tools, right? We can access the world's information. We have all these applications. I mean, this is a really powerful computer, and we just carry it with us. We don't even think about it. It just becomes part of the background. And that's what's really powerful. And we will get there soon with these AI tools, I believe.
Any final comments or thoughts that you wanted to leave for the discussion?
No, just that I'm really optimistic about the future. I guess I'm an optimistic person anyhow. I think that we have a number of challenges in healthcare, particularly in primary care, that we talked about earlier. But I'm optimistic about the when we apply technologies wisely and well, and we really work hard, we can solve these problems. We can really address a lot of the problems of scaling the healthcare system, improving joy in practice, improving patient satisfaction, improving participation. There is so much that we can do, and I'm just so excited to work on it.
Well, thanks so much for taking your time out to be able to have this conversation. Really appreciate it.
My pleasure.